Stay with us for the next 30 minutes as you meet our doctors like never before. A program that will allow you, our viewers, to make more informed decisions when it comes to your health care.
I'm Tracy Morgan. I'm the Director of Marketing and Community Relations here at Fairview. And we work hand in hand with the guys here at Fairview Medical Group Orthopaedics. We have found that there are numerous orthopedic issues in our community. So Dr. Dustin Gay is going to be presenting today for us. He is fellowship trained in the anterior approach to hip replacement. And I'm just going to let him take it away.
A lot of times when I do these talks, we do PowerPoints and I go through slides and talk and you guys sit there and listen, and it's not as interactive. So what I decided to do today to mix it up a little bit is get a board out and do kind of what we call a chalk talk, where I just kind of talk sort of off the cuff about knee pain issues and really give you guys more of a chance to do a question and answer session rather than me stand up here and talk the whole time. So you can ask questions in general or specifically about what's going on with you. Tracy, you set this one up. A lot of times I give hip talks and Heath gives knee talks, but she set this one up for me to talk a little bit about knees, which for me generally is talking about knee replacements because that's the majority of what I do, but we'll talk a little bit about everything from sports injuries to the knees to arthritis. So you guys feel free to stop me at any point, ask questions. Like I say, just keep it very informal today. So what I've done up here is drawn a non-artistic, non-anatomically correct drawing of the knee because I'm not much of an artist. That's why I'm a surgeon. But anyway, this is what a knee looks like from the front. So this is your femur bone up top, or your thigh bone in your leg, and this is your lower leg bone, or what we call the tibia. Okay, so thigh bone or femur, lower leg bone or tibia. There's actually two bones in your lower leg, so there's another little small bone that sits on the outside over here called the fibula, or if you read Yahoo email talking about the NFL, they call this the tibula in a recent article, which is completely not correct. But anyway, that's beside the point. You'd think they would have editors that get that right. So this is looking at the knee from the front, or sort of like an AP x-ray of the knee. This is looking at the knee from the side. So this is your femur and your tibia again, and then the small bone would kind of sit back here called the fibula. This is your kneecap, or what we call the patella. So what can go wrong in knees? Well, and I kind of wrote a list out over here. So there's ligaments in our knees, what you hear about the NFL players or the college players tearing. So if you look at ligaments in your knees, there's a ligament on the inside. So this is the inside of the knee, this is the outside. There's a ligament on the inside of the knee over here called the MCL. There's a set of ligaments on the outside of the knee over here, what we call the LCL, or lateral collateral ligament, medial collateral ligament. And then there's two ligaments in the middle of the knee that kind of make an X, which are the ACL and PCL. Okay, these are the ligaments you hear about ball players tearing. They tear their ACL, or they tear their MCL along with their ACL, or they tear all three. Or if you're Willis McGahee and you dislocate your knee, you tear everything that's in there. So that's sort of the ligamentous problems, and that tends to be the younger patient population that have knee injuries, true sporting event injuries. Usually when people get to my age, their mid-30s, into their 40s and later in life, they don't often tear their ligaments, although they can still tear their MCL, maybe their ACL. But if I tear my ACL, unless I'm going to go out and keep playing basketball, I don't really need an ACL anymore. I could live and do daily life activities without an ACL or with torn ligaments in the middle of my knee. This ligament, the MCL, people tear sometimes even later in life. This is the one ligament in the knee that if you tear, that gets no surgery. We just let it heal. We figured out you put it in a brace, let people be active, and their MCL heals. Better without surgery than with surgery. ACL and PCL tears, if these ligaments get torn and you're young active, those get fixed with arthroscopic procedures now. And when I say arthroscopic, what does that mean? Well, it's through little tiny poke hole incisions in the front of the knee. So we make a little incision up here and up here in between the bones of your knee, and we go in with a camera and little instruments through those poke holes and fix those ligaments in various ways. We can talk about that in more detail if somebody's got a question about ligamentous injuries of the knee. But that's kind of your young patient sports types injuries to the knee. The next sort of class or group of injuries to the knee is muscles and tendons. A lot of times people kind of forget about this. You hear about ligament injuries, you hear about arthritis, you don't hear a lot about muscle injuries. But I see a lot of people that come in that have muscle or tendon injuries in their knee. If you look at this sort of a schematic or drawing from the side, your muscles, your quadricep muscles, which is a reason it's called quadriceps, it's a group of 4 muscles in your thigh, the big muscles on the front of your thigh that come down and attach to your kneecap. Okay? Then there's a tendon called the patella tendon that connects your kneecap to your lower leg bone. When you straighten your knee, your muscles, your quadriceps, contract or fire. They pull on your kneecap and they lift your lower leg up. That's how we straighten our knee. Okay? So how do people get injuries related to that? Well, people will fall a lot of times. They'll slip and fall with their knee or their leg bent underneath them. And then they get injuries, either strains of this muscle or tears. They tear their quadriceps completely off of their kneecap and rupture it. And then they come in, they can't walk because they can't keep their knee straight and they can't straighten their knee all the way out. Sometimes people get fooled. They say, well, I didn't tear anything because I can still sort of straighten my knee out. Well, if you tear your quadriceps completely in half where I drew this line here, off of your kneecap, there's still tissue that surrounds your kneecap, what we call the retinaculum, but it's a thin layer of tissue that can still allow people to sort of straighten their leg out, but they won't be able to straighten it quite all the way. And if they try to hold their leg straight with me resisting it or pushing on it, they can't do it. It's not strong enough. So just because you can straighten your leg some doesn't necessarily mean that you didn't tear this. So that's called a quadriceps rupture, which is a fairly common injury in people as they get older, in their 40s, 50s. Younger people, for whatever reason, tend to tear here. They tend to tear their patella tendon. It's called a tendon because there's no muscle attached to it. It connects your kneecap again to your lower leg bone. And it's the same symptoms if you tear it there. Pain, swelling, big swollen knee, and you can't straighten your leg out. Okay? So that's the major muscle and tendon injuries that occur around knees. You also have your hamstrings, which are the muscles in the back of your leg. That's what bends our knee. So those muscles live back here behind your femur bone. And they come down and attach on your tibia, your lower leg bone on each side. If you bend your knee and you feel like a band or thick band of tissue on the inside and on the outside behind your knee, that's your quadriceps tendons. Those, again, bend your knee. People can tear their quadriceps, but that's a much more rare injury because we don't typically fall and our leg hyperextend, meaning our lower leg come forward. I have seen people tear these skiing or rupture them off of their, what we call the ischium, which is the bone up here in your pelvis or in your buttock region where those muscles attach. But these typically don't get treated. These typically don't need surgery. You do physical therapy, you let them heal. These injuries up front, if you don't fix these, people don't walk. So those get fixed with surgery by me reconnecting those muscles to the kneecap by drilling holes through the kneecap and tying those muscles back to it with suture. Or you can use what we call suture anchors, which are little like screw-in metal pegs that you screw into the bone that have stitches or suture attached to it that you tie the muscle back to the bone with. So that's how those get fixed. The sort of last class of injuries to knees, and which is the most common, it's the most common thing that I see when people coming in complaining of knee pain, because my patient population tends to be people in their 40s and up. Dr. Richner, my partner, tends to see most of the kids with sports type injuries. So what I see is what's called cartilage injuries in the knee. Okay? So let me get rid of some of this stuff here, so we can make this simplified back down so it makes more sense. So if we go back to just our bones of the knee, femur and the tibia, what do we mean when we talk about cartilage in the knee? Well, there's really two types of cartilage in people's knees, okay? And you hear people, they come in and they'll say, well, somebody told me I tore my cartilage. Well, which cartilage is kind of the question. So there's the meniscus, and then there's cartilage on the end of the bone, or what we'll just call bone cartilage for today. We won't get into details of the difference necessarily and what makes them what they are. But we all have cartilage on the end of our bone, on the end of our femur, and on the top of our tibia, which is white, shiny cartilage, just like on the end of a chicken bone. If you go eat lunch and you get a piece of Maryland fried chicken and you eat all the chicken off and you look at the end of the bone, it's got that white, shiny stuff on the end of it, everybody's seen it. That's cartilage, okay? All of our bones at our joints, elbows, wrists, fingers, knees, hips, they're all lined with a cartilage surface on the end of the bone, which is that white, shiny stuff that makes our joints able to move without being painful, okay? Cartilage does not have nerve endings in it, so it doesn't hurt when you bend and straighten. Your joint, in addition to having cartilage on the ends of the bones, has a lining around our joint, which we call the capsule. Okay? Which is just I describe to people as a balloon lining around your joint. Why is that there? Well, in addition to having cartilage on the end of our bones, we also have fluid or liquid in our joints that help them move. It's the lubricating portion of our joints. It's just like a ball bearing on a vehicle, or the grease that you use to lubricate it. Our body puts fluid in your joint to lubricate it. Okay, that's how it moves smoothly, and that fluid provides nutrients to this cartilage to keep your cartilage healthy. Because in addition to not really having great nerve endings, although there are some, our cartilage doesn't have good blood supply to it, so it doesn't get what it needs to stay healthy from your blood. It gets it from that fluid that floats around in your knee. That's why cartilage doesn't heal when it's injured. It doesn't have blood supply to it to heal like muscles or other organs and things in your body. So when you tear your cartilage or injure your cartilage, it doesn't really heal very well. So this is the first type of cartilage, okay? It's on the end of our bones. It's just that lining on the end of the bone, on both bony surfaces. The other type of cartilage in your knee that people injure is what's called the meniscus. And you've probably all heard about it or had people say, well, I tore my meniscus. The meniscus is truly the cushion pad in the knee. So if you look at this drawing of the knee again, and I'm going to take this away just to limit confusion. You've got the cartilage on the ends of your bones. In between those bones then sits a cushion pad, which looks like a triangle on the inside and on the outside. If you look at it from this view, if I can make this a little more. It's a triangular pad if you look at it from the front. One on the inside over here, one on the outside. If you look at it from the side view, it's difficult to see, but it's a thin cartilage that lines in between the bones. And that's what's called the meniscus. If I cut your leg in half, and I typically don't do that because people don't heal very well when I do it. But if I cut your knee in half and look down on those cushion pads, they look like two C's, like this. Again, one on the inside and one on the outside. That's what these cushion pads look like if you look down on them. Okay? So what do people injure, or what problems do they get? Well, if you're younger and you haven't developed arthritis yet in your knee. Now let me back up. Arthritis, just to kind of clear it up, because it gets confused, what is arthritis? Okay, what does that mean? All arthritis is wearing away of this bone cartilage, this cartilage lining on the end of our bone. It's simply wear and tear. That cartilage surface wears down or wears out and gets thin, and you start exposing the bone underneath it. That's all arthritis is. It's not like pneumonia. It's not something you catch. It's not, oh, my mom had arthritis and she gave it to me. Well, that's kind of true in that genetics plays a role in how well people's cartilage holds up as they age. So if your parents have arthritis, you might get it as you get older, but it's not a disease in the sense of the way we think about diseases that you catch, pneumonias, viruses, colds. It's just a pure wearing out. Now, there are other types of arthritis which some people have, like rheumatoid arthritis or lupus arthritis, which instead of just being wearing out of the cartilage, your body's own immune system, my body's immune system that fights colds and does things like that for me to help keep me healthy, actually attack your cartilage and wear it away. It's still the same end result, meaning that bone cartilage, that lining of the end of the bones gets worn away, but it's not just from wear and tear over the years of squatting or doing heavy lifting or playing sports. It's that your own body chews that away. Okay? But all arthritis is my cartilage on the end of my bones worn out. It's not there anymore. The cushion pad problem, the meniscus problem, tends to be in people that are younger, 40s, maybe 50s, sometimes older if they maintain good cartilage. But what happens? Well, they have some event where they twist their knee or they kind of torque their knee, may not even remember it. And you develop a tear in this cushion pad. Draw it with another color. So this cushion pad, which is it's a rubbery-like substance. We don't have a model that's got one in. But it's a rubbery-like substance that's shaped like that C that sits in between the bones. And that rubbery cushion pad or rubbery substance can develop a tear in it. So it gets a small tear in it. Well, what happens? Well, when there's a tear, then this area right here becomes like a flap. Because it's torn, it doesn't sit down in between the bones the way it should, sit there smoothly and act like a cushion pad or a shock absorber. That flap or that tear can then move. That piece of that rubber cushion pad moves around in your knee, can actually flip completely 180 degrees over and cause people's knee to lock, or it just irritates the knee. As it moves around and gets in positions that it shouldn't be in, it causes pain in the knee. And then as a result of that pain, your body responds to pain or problems in your knee by putting extra fluid into the knee. Remember we talked about how the fluid lubricates your knee? Your body puts extra fluid in there because it hurts, right? My knee's hurting, something's wrong. Your body responds by pumping extra fluid into it. Well, what does that do? Does it fix the problem? No, it makes the knee swell. That's why people's knees swell. It makes the knee feel tight, so people come in and they complain my knee's stiff or tight feeling, and they can't bend it as much because that extra fluid in there makes it harder for the knee to bend and straighten. Remember, it's like a balloon lining. If I fill that balloon up real tight, then I can't bend and straighten my knee very well. If there's only a little bit of fluid in that balloon, then my knee moves better. So these tears, whether you get it on one side, whether you get a small tear, or whether you get a big tear. Sometimes people just have a small tear. Sometimes they get a tear that goes all the way through the cushion pad. And that whole piece back here is loose and moving around. How do we treat these? Well, if it's a meniscus problem, we generally try to treat them without surgery to start with. Okay, my goal is to make you better without having to take you over there to the hospital and put you to sleep. Sometimes I can't do that. But if I can, that's what I want to do. So I treat this just like we do arthritis to start with medicines that we call NSAIDs. Boy, I can't write it today. Which are non-steroidal anti-inflammatory drugs. That's what it stands for. It just means it's a medicine like Motrin, Advil, Aleve, or prescriptions of those which are Mobic, Meloxicam, Celebrex, Vimovo, that's a new one. There's probably 10 or 15 of them that are prescription forms. They all work the same way. They're just pure anti-inflammatories. Physical therapy for range of motion and strengthening. The stronger those muscles are that I drew that surround your knee, the less pressure your cartilage on the end of the bone, the less pressure your meniscus or the cushion pad in your knee feels when you do activities. That's why physical therapy helps, even though people sometimes are like, why are you sending me to physical therapy? I got a torn cushion pad. Well, that's why. Your muscles are also shock absorbers around your joints, and if they're stronger, you're going to have less symptoms even if you have a problem. If these things don't work, then you can do shots, which is generally cortisone is the first shot. What's cortisone? It's basically like taking those NSAIDs. It's an anti-inflammatory, but instead of you taking it by mouth, it getting in your bloodstream. We talked about how there's not great blood supply into the knee, but they still help some. I take that It's in a shot form. I put it in your knee joint, inject it in there. So I'm taking that anti-inflammatory medicine and I'm putting it right where the problem is. So cortisone usually helps and gets rid of the symptoms even if you have a torn cushion pad. Now, the problem is when you develop recurrent symptoms, meaning I give you a shot, you do some therapy, your symptoms get better, but then they keep coming back. Your symptoms are what we call recurrent, where you still have swelling after the shot wears off. That's when we have to talk about doing surgery, okay? Which generally means going in through those poke holes on the front of the knee. And what do? Well, if you've got a tear, and most of the tears aren't all the way through like that. Most of them tend to be on the inside, more common than the outside, and they're usually a little line or a tear. And all we do is go in and shave that portion out. So I take all of this out, and I make a smooth surface on the inside again. Well, what does that do? Well, it stops that piece that's flipping and moving around from irritating the knee and takes away the symptoms. Does it leave you with less cushion pad than you had before I did it? Yeah, absolutely. Does that make you develop arthritis down the road? It might, but not any more than having a tear that you're just living with, because that torn portion of the cushion pad is what we call non-functional, meaning it doesn't work the way it's supposed to anyway. So taking it out might slightly increase your risk of arthritis, but we think that risk is already there anyway. That's hard to prove in studies. So that's how we treat meniscal tears. Do we ever fix these? Meaning go in and put a stitch across the tear. Well, that makes sense, right? Instead of taking it out, just fix it. Well, we've done that in the past. The problem is, like we said, there's not much blood supply to these. The only blood supply to the meniscus is in the outer 1/3 or the outside edge of it. Most of these tears are not in that area. So we've learned if you go in and you put a stitch across that tear, it lasts only as long as the stitch holds up. When the stitch wears down and the stitch breaks again, the tear's still there because they don't heal. So we don't fix them most of the time anymore. We shave them out. So that's sort of meniscus. That's the cushion pad tears or the cushion pad things that cause knee symptoms. The final thing is arthritis, which we talked a little bit about. That's a problem with the cartilage on the end of the bone. That's a different cartilage problem than the meniscus problem. A lot of people will come in and have arthritis in their knee, meaning their cartilage on the end of the bone's worn down, it's worn out. They're maybe in their 50s or 60s or 70s or 80s, and they've just worn their knee out. They start developing bowing of their knee. Their knees may bow out, their knee may bow in. That just depends on whether the cartilage wore out faster on the inside or the outside of their knee. Everybody who has bad arthritis, meaning their cartilage has worn out on the ends of their bones in their knee, will 100% of the time have tears in these cushion pads. So some of the confusion comes in. I see people that come in their 70s to see me and they say, well, I saw my medical doc, he's been giving me medicines and giving me shots, and then I got an MRI of my knee and it shows I got a tear in my meniscus or my cushion pad and I need that fixed. Well, the problem is if you've got bone-on-bone arthritis, meaning your cartilage is worn away here and here, and these two blue bone surfaces are now touching together, there's no red cartilage left. Well, what do you think the cushion pad is going to look like once those bones start rubbing together? They're all going to have tears in them. So if I take everybody in this room who may happen to have arthritis in their knee and I do an MRI of it, every one of you is going to have a tear in that cushion pad. Because when the bones start grinding together, the cushion pad is going to get torn. That's not the problem. Going in and scoping, doing a surgery, an arthroscopy where we go in with the camera again and cleaning out your cushion pad tear if you've got an arthritic knee and, quote, cleaning up the arthritis, we've learned doesn't work for people. Now, in years past, we used to do that. We'd go in and, quote, clean the knee up. There's still some of that when you kind of get in the sort of in-between phases. Your arthritis isn't terrible. It's maybe mild arthritis. You do have a cushion pad tear. Will a surgery, a small surgery where I go in with a scope and clean things up, will that help? There's a fine line. You have to talk to the patient a lot and try to decide if their main symptom is arthritis, which a knee scope doesn't help, or is their main symptom a cushion pad tear, which a knee scope will help. you have to balance that when you get that sort of in-between patient. But for the most part, knee scopes don't work for arthritis. How do we treat arthritis? Well, same philosophy to start with. NSAIDs or medicines by mouth, shots, and physical therapy. When these things don't work, then you're left with joint replacements. So what we call a TKA, or a total knee arthroplasty. There's also something called a UKA, which is the abbreviation, or a unicompartmental knee arthroplasty. Those are the sort of inline treatment for arthritis. If your cartilage is worn out and I can't make your symptoms go away with medicines, therapy, injections, then you're left with me fixing your knee. Well, fixing it means going in, shaving the cartilage off the ends of the bones or cutting the ends of the bones to get rid of those worn out cartilage surfaces. I don't lop your leg bone off up here, okay? But I cut the ends of the bones off and then I replace it with metal and plastic. And that's what this is a model of, and I'll pass it around so you guys can play with it. When I really do them, I put them in better than that. So they don't fall off.
And I'm going to pass this around too if you missed the sign-in sheet. I think we've got some that did.
So this is a model of these same drawings that I've been drawing, okay? Thigh bone, lower leg bone, the ropes on the side are the ligaments. So MCL, LCL, or medial collateral ligament, lateral collateral ligament. When you get a knee replacement, those ligaments are left alone for the most part. Sometimes if you've got bad arthritis, then I have to do some things to what we call balance those ligaments, meaning to give you the same tension on the inside and the outside, but these ligaments don't get cut. The ligaments in the middle of the knee, remember I said you can live without those generally when you get older. When I do a knee replacement, cut those out anyway. Take them away. The knee replacement replaces those, and I'll show you how that works. But what do I do? Well, I shave your bone off on the ends in this fashion. So you can see how the thigh bone is shaved off in sort of like almost a half of a stop sign, but these sharp angled shapes. And then I shave the lower leg bone straight across the top, flat, with a little bit of slope front to back, but 90 degrees to the long axis of your lower leg bone. I have, tools and instruments that help me do that. I then cement a metal cap onto the end of the bone, or glue it into place. It's not really a glue, it's more like a grout, but it locks this metal piece to your bone. I then do the same thing in the lower leg bone, meaning I cement or glue a tray down to the bone that has a little metal stem that goes down inside the bone. And then I'll lock a piece of plastic, or what's called polyethylene, in place, and that becomes a knee replacement. The plastic or polyethylene acts like your cartilage did. There's a little metal or a little plastic post in the middle right here, and that gives your knee some front to back stability. Okay, that sort of replaces the ACL and PCL, although you don't really need an ACL at all. Your kneecap, which sits up front here, I flip over. I think this model's actually got, this is another model of knee replacement that has the ligaments, more like ligaments, and it has your quadriceps muscle, remember which we talked about, that comes down and hooks to your kneecap. Your kneecap, the bone I leave there, but I shave the back of it off to get rid of the cartilage on the back of our kneecap, because your kneecap, again, which sits up front here, also has cartilage on the back of it. So I shave that off because that's typically worn out, and put a plastic button on the back of it, and that plastic button then slides up and down in that metal groove. So plastic or polyethylene here to replace the cartilage, plastic or polyethylene there to replace the cartilage, and that becomes a knee replacement. A unicompartmental knee replacement, if you only have arthritis, say just on the inside of your knee, occasionally if it's the right patient and they have absolutely no arthritis on the outside or behind their kneecap, I'll do what's called a partial knee replacement or unicompartmental knee replacement. And that's basically half of this. It's just a little metal runner that goes on the inside, a small metal tray which just goes on half of the lower leg bone, and a small piece of plastic which locks in between the two. I generally only do that in very young people, say somebody in their 40s, maybe 50s that have arthritis just on the inside of their knee that I know is going to wear a knee replacement out in their lifetime and need to have it done. Knee replacements probably in today's world are going to last somewhere between 20 and 30 years with the new plastics that we have. If you're 50, life expectancy now in the 70s and 80s, you're probably going to wear that out. So I would consider doing that in somebody with the right arthritis pattern who's young. Or you've got the 80-year-old that only has isolated arthritis on the inside of their knee. And they're maybe not as healthy. I want them to have a smaller recovery process. And I know that if I can give them something that just takes away that inside knee pain, they're probably going to be happy. That's the other patient that I'll do that in. If you're in your 60s, you're kind of in that mid-range, 60s to 70s, a knee replacement's probably going to last you your lifetime. So I typically give that person a full knee replacement. I know it's going to last them their lifetime. I don't have to worry about them coming back and developing arthritis on the outside in the next 10 years and having to redo it. The 80-year-old who's got just arthritis on the inside probably ain't going to develop arthritis on the outside if they've reached 80 and they haven't done it yet. That's why they can sometimes get the partial knee replacement. But these are what knee replacements look like. I'll just pass these guys around and y'all can just kind of look at them. So that's sort of an overview of what causes knee pain in people, the different kind of categories, and sort of how we treat them. I think I'm just going to open it up for questions for you guys at this point. You can ask specifics about any of this stuff or different things that you've dealt with your knees. And if it's something we didn't go into detail, like ligament injuries and stuff, then I'll talk about it more. Yes, ma'am.
What about injections of fluid?
Injections what?
Of fluid in your knees?
Cortisone? Yes. So that's the shots or treatment that we talked about here. Cortisone is an anti-inflammatory. That's how it functions to make knee pain better. It does not fix knee problems, meaning if you've got a cushion pad tear, it doesn't make the cushion pad tear heal. If you've got arthritis, it doesn't make the cartilage regrow. But it is a liquid medication.
But what about that? It's S-Y-N-O-V-I. Synovial.
Synovial fluid is what the fluid that your knee makes naturally is called. Okay. We don't inject synovial fluid into knees. We don't really know how to make it. Now,
there's something that I know they say you can't use it if you're allergic to
eggs.
Birds or eggs. Or
so those are what's called. I probably should talk about these a little bit. Those are what's called. Some people refer to them as visco shots. VISCO shots, rooster shots, gel shots. They got all kind of names out there. They are, most of them, some of them are synthetically made now. Most of them are made, the reason they call rooster shots, they're made from chicken combs.
Right.
So they take chicken combs and grind them up, and that has building blocks of cartilage in it. They make that into a gel or liquid-like substance, and then we inject it into the knee. Okay, what does that do? Well, we mainly use it to treat arthritis. Don't really use it to treat meniscal tears, although it might work for that. It's not approved for that. It's when we inject that into your knee, it does not rebuild cartilage. Okay, that's what some people think, or that's what we'd like to happen. But when I inject that into your knee, it makes your knee make a little bit more normal synovial fluid. You remember how I talked about your knee was making too much fluid? It somehow seems to calm that process down where you don't make too much fluid. And the fluid that it makes tends to be a little bit maybe thicker, a little more lubricating, and it takes away pain. It has some anti-inflammatory properties to it for some reason. Honestly, we don't understand the entire microscopic level of exactly what those injections are doing to fix your knee or make your symptoms go away, because it does not make the arthritis or the wearing away of the cartilage heal, but it does make people feel better. The problem with these shots is they're 3 to 5 shots, one injection a week, although there is one called Synvisc 1, which is a single shot. There's some mixed reviews about that actually being a single shot. It was initially designed as a 3-shot series. the company basically combined it into one larger shot and got it pushed through the FDA. But it's a lot of fluid to put in the knee at one time, so I don't really like that shot. We use what's called Suparts, which is just one variation of it. There's Synvis, there's Suparts, there's Hyalgan. I think there's a couple more out there now. But that's what those are. They're called viscosupplementation, lubricating injections, rooster comb shots, whatever you want to call them. That's how they work. That is a good option for treating arthritis. It's not as reliable, I don't think, as cortisone, and the studies would kind of support that. Cortisone, if you've never had a cortisone shot and you've got arthritis, it's probably going to make you feel better the first time you get it. Now, it might last for a week, it might last for 2 days, it might last for a year or more. And there's no way to predict how long it's going to work. Some people don't work at all, but that's the rare exception. These lubricating injections, I tell people it's about a 50-50 shot. It's probably more like 60-40 that it works versus it doesn't work. If it works, it tends to work very well for people, meaning they get great relief of their symptoms. If it doesn't work, it tends to not work at all. So it's almost an all or none phenomenon. It doesn't typically make people come in and say, well, it's about 50% better. They generally come in and say, boy, this feels good. It's like 90% to 100% better. Or they say they didn't do a thing. And I tell people that ahead of time. This may not help you at all. But if you don't want surgery and you've got arthritis and you've failed medicines by mouth, or you can't take those medicines because you have heart problems, or you've had bad stomach issues and you can't take those medications, and you've failed cortisone, your option at that point is surgery, or you can try these other injections. And depending on how bad people's arthritis looks, I'll kind of steer them sometimes in one direction or the other, but I'll let you make the decision. Are you ready for surgery? Not ready for surgery. If you're not, we'll try these injections, but it's probably a 50-50 chance whether or not it's going to help.